Dr. Jordan Rullo. She is a board-certified clinical health psychologist, a certified sex therapist and supervisor through the American Association of Sex Educators, Counselors, and Therapists, and she's a certified Gottman therapist. Jordan is no stranger to Image Reborn. She came a few years ago to a retreat that we held specifically about body image and sexual wellness, and we were just blown away by her. She is so bright, so well articulated, and the information she provides is just so incredibly helpful and important. So thank you so much, Jordan, for being here. And are you all set up with your...
I think I'm set up, but I don't know where my...
Okay, let me get you going.
I'm halfway there.
So please welcome Jordan Rullo.
Testing. Oh, good. Sounds like it's working. Well, I was super nervous, and then we just got to dance, and I was like, thank you for that. So I feel a little bit less nervous now. Let's make sure this works. It does. Great. Okay. Well, thank you everyone for being here. So my talk today is on the impact of breast cancer on sexual health. I'm going to talk about 3 different women and kind of weave them throughout this presentation, so I want to introduce you to these women first. This is Sarah. Sarah says, I have no sexual interest. If I didn't have sex for the rest of my life, I'd be fine. She's a 38-year-old heterosexual married woman, breast cancer status post total abdominal hysterectomy and bilateral salpingo-oophorectomy. Okay, next is Nancy. Nancy says, we haven't had sex in 5 months. It hurts too much. I'm desperate. She's a 49-year-old heterosexual married woman, breast cancer status post total abdominal hysterectomy and bilateral salpingo-oophorectomy. And then we've got Kelly. Kelly says, I can't even look at my breasts, let alone let my wife look. I haven't let her touch me since my surgery. 29-year-old lesbian married woman, stage 2 breast cancer, status post bilateral mastectomy. So we'll talk about all 3 of these women and their concerns in the presentation today. So this is what we're going to talk about today. We're going to review the sexual health concerns of breast cancer survivors, describe the treatments for breast cancer-related sexual health concerns, and then finally explain how to navigate your sexual relationship in the context of breast cancer. Okay, a little bit of a quiz. You cannot fail this quiz. Between what percent and what percent of breast cancer survivors report sexual health concerns? 10 to 20, 30 to 60. Just yell it out there. What do you think the range is? 50 to 90, that was the loudest one. Yeah, thank you so much. 50 to 90. That's pretty good. 70 to 90. And I mean, you all know this. You're living it. But sexual health concerns related to breast cancer pretty much impact almost every woman. And here's the thing about sexual dysfunction. It does not just simply get better over time. So a lot of the side effects you're experiencing, maybe your oncologist is telling you, well, just kind of wait after X number of months or years, this is just going to get better over time after time has passed. That is not the case for sexual dysfunction. Sexual dysfunction just doesn't get better over time just by watchful waiting. It has to get treated. It will get better over time with treatment, but action has to happen for it to get better over time. So what do? If you're having sexual function concerns, like what are those options? What do you do? Well, we're going to get into that, but one thing I want you to remember from this talk, if this is the only thing you remember, is that breast cancer does not take away your sexuality. It does not. It's going to change it. You're going to experience your sexual function differently, your sexual sensations differently, more than likely, but it is not going to take away your sexuality. So we're going to talk about what is this going to look like if your sexuality looks different or your sexual function looks different. There are treatments for sexual health side effects after breast cancer. There are treatments. Okay, so the most common sexual health concerns after breast cancer are low sexual desire, sexual pain, poor body image, and an avoidant sexual dynamic. And these are the 4 things I'm going to talk about today. And we're going to talk about how to treat them and then how to navigate your sexual relationship within these things, within these issues. So we're going to start with low sexual desire, which brings us back to Sarah. Again, Sarah says, I have no sexual interest. If I didn't have sex for the rest of my life, I'd be fine. And so if you're thinking, yeah, like I've absolutely thought that too, then pay attention because I'm going to share with you, like, what does Sarah do in this situation? So there are two types of sexual desire, and I've got to explain each of these types of sexual desire for this to start to kind of make sense. So the first type of sexual desire is what's called spontaneous desire. And spontaneous desire is that type of desire where you just spontaneously think, ooh, I really want to have sex right now. Okay, so that's spontaneous desire. Second type of desire, equally important, but we certainly don't hear about this in the movie or the medias, and if you did get sex education, it's definitely not talked about in sex education, and this is called responsive desire. So responsive desire looks like this. You are sexually neutral. Sex is not on your mind, you're not thinking about it, but the ingredients are in place that allow you to be responsive. And so maybe those ingredients are, you've got good energy, you feel relaxed, you feel close to your partner, there's privacy, there's some good ringtone music going on. So those are some of the ingredients. And then your partner initiates. And if you don't have a partner, maybe it's not your partner initiating, maybe it's something sexy on television, maybe like Bridgerton just got on TV. And you're like, well, I mean, I wasn't thinking about sex, but okay, I mean, I'd be open to it. And then what happens next is the sexual activity kind of starts, your body starts to get aroused, and then after your body starts to get aroused, your mind goes, well, yeah, I'm kind of glad we're doing this. So that's responsive desire. We got spontaneous, you just spontaneously think, gosh, I really want to have sex right now. Responsive desire, you start from this neutral place, as long as those right ingredients are in place. You think, okay, I'm open to this, and then after a while, your mind says, yeah, I'm glad we're doing this. So spontaneous versus responsive, both are equally important, and we certainly don't often hear about the responsive desire. Now let me show you, I want to show you responsive desire kind of graphically. If your main type of desire is responsive, it fits in what's called the circular model of sexual response. I know this looks really complicated, so let me explain this. Let's see if this pointer works. Oh, good. Okay, so if your main desire is that responsive desire where you know, like, yeah, I need to get ingredients in place. I'm typically pretty neutral, but once those ingredients in place, I can be open to it. This is what this looks like. So you're receptive, you're open to being sexual. There's some sort of sexual stimuli, which might be your partner initiating, might be something sexy on television, might be a sexy book you've got on your nightstand, but there's some sort of stimuli. As long as biologically and psychologically everything's in check, meaning you're not in a pain in that moment, you don't have a massive headache, you're not depressed, you're not stressed out in that moment, as long as these are in check, what happens first is your body starts to get aroused. So if the right buttons are being pushed, your body starts to feel that some of that sexual arousal, blood flow. Then on the coattails of that comes the desire. And this is a super important piece about if your main desire is responsive desire. The super important piece is arousal comes before desire. Arousal comes before desire. Your body has to get going. Maybe there's a little bit of kissing, some touching, but your body has to feel some of that arousal. And then your mind says, oh yeah, okay, I'm kind of into this. Which is a lot different than that spontaneous desire, because that spontaneous desire just starts from like, I'm into this, let's do this. For this one, it's kind of neutral, then arousal starts, then your mind says, I'm into this. That leads to some sort of emotional and physical satisfaction. That could just be feeling really close to your partner. That could be orgasm, lots of different ways people define satisfaction. That leads to feeling intimate with your partner, which leads you to seek out or be receptive to sexual activities in the future. So if your main desire is this responsive desire, the circular model is your main model. Now, you can see in the middle here, it says spontaneous sexual drive. If your main desire is that responsive desire, that doesn't mean you don't have spontaneous desire. You may still have some spontaneous desire. So if you just have some spontaneous desire sometimes, what will happen is that spontaneous desire kicks up, and maybe it leads you to seek out stimuli and initiate with your partner, or turn on Bridgerton or Outlander, or maybe it leads you to just feeling aroused in that moment. Those are the two shows I hear from my clients all the time, Bridgerton and Outlander. And Bridgerton. And so what women will talk about, this is a total side note, but they'll say, I know my main desire is responsive desire, and I know I have to kickstart it in some way, so we'll put on Bridgerton, we'll put on Outlander, and that kind of gets it kickstarted. Okay, so let's tie this into breast cancer treatment. Spontaneous desire, if you think about spontaneous desire having a gas tank, most of the gas that fills that gas tank, that drives that spontaneous desire, is hormones and then novelty, like that honeymoon stage in your relationship. But if you're on any sort of medication, or let's say you had an oophorectomy, any chemo, aromatase inhibitors, surgery that's going to impact your hormonal function is going to impact the hormones in that gas tank. So all of a sudden, half your gas tank is empty. And then, if you've been in a long-term relationship, you're not in that honeymoon phase anymore. So what research shows is that honeymoon phase where you think your partner's just adorable and they can burp and fart and you think that's still cute, that's only at most 12 to 36 months that can last. And I can tell you, as a couples therapist, I have never seen a couple in my office that is still in that honeymoon phase at 36 months. It seems to kind of end at like the 6-month mark. But if you've been in a long-term relationship, you don't have that novelty, that honeymoon phase gas in your tank, which means that spontaneous desire is probably not going to be your main desire, so you're left with that responsive desire, which is still a really great desire. It's just a much more planful desire. You really need to know, well, what ingredients do I need to be in place? What ingredients does my partner need to help me have in place in order to kickstart that responsive desire? So talking about ingredients, there's a model, it's called the dual control model, that does not sound fun, but it's actually really cool, that can help explain this ingredients piece. Like, yeah, what ingredients do I need in place? So the dual control model is based on a bunch of really cool research that shows that when it comes to sexual function, let's just say sexual desire, in order to have desire, your desire consists of a brake pedal and a gas pedal, and you need to have more on the gas than on the brakes. So what typically hits a brake pedal? It's going to be things like how you feel about your body image, if you're tired, of course, chemotherapy and those side effects, depression, anxiety, stress, all those things are going to hit your brake pedal. So what hits your gas pedal? Maybe your partner smells good, maybe they look good, there's novelty in the relationship, you feel emotional connection. So here's what the research shows. In order for you to have desire, or name the sexual function, in order for you to have orgasm, in order for you to feel aroused, but we're just talking about desire right now. So in order to have desire, if your desire is made up of a brake pedal and a gas pedal, again, in order for sexual function to function, in order for you to have desire, you need more on that gas than on that brake. Now, most of the people that come in my office for sex therapy, I ask them, because I'm trying to assess, well, what's on your brake pedal, what's on your gas pedal, what have you done to try to kickstart your desire? And they'll typically tell me things they've tried to put on the gas. Well, we've done date nights, we've done lingerie, we tried to bring toys in. And that may all be helpful at a later point, but initially, it's what's hitting the brakes that is most important. Because think about this as a car. If you've got your foot all the way on that brake pedal, and then you decide to put your foot on the gas, what's going to happen to your car? No, it's not going to go anywhere. Maybe the engine's going to rev, but it's not going to go anywhere. So if you have a ton of weight on that brake pedal, everything you put on the gas, all the lingerie, date nights, toys, doesn't matter. What's most important at the beginning is what is on your brake pedal and trying to remove as much as possible off that brake pedal. If you can get weight off that brake pedal, then you can start thinking about things to put on the gas. So when I see a woman for sex therapy or a couple for sex therapy, immediately I'm trying to work on what is hitting your brake pedal, and let's see how we can remove as much as possible off that brake pedal. And this helps you identify if your main desire is that responsive desire. Well, what ingredients do I need in place? If you know what hits your gas and you know what hits your brakes, then you're starting to identify what are those ingredients. So let's talk about most common things that hit the brake pedal. The most common thing that hit the brake pedal fit really nicely into what's called the biopsychosocial model. So essentially, there are things that hit the brake pedal that are physiological, things that hit the brake pedal that are psychological, emotional. There's relationship stuff that hits the brake pedal, and there are sociocultural influences that hit the brake pedal. And I'm going to walk you through the most common areas in each of these columns that hit the brakes. Take a moment, if you are struggling with low sexual desire, looks like a lot of you have like notepads, or if you have your phone on you. As I'm going through this list of the most common things that hit the brake pedal, jot down what of these hits your brake pedal, because this is going to be the start of working on your desire. If you know what's hitting your brakes, you can start to work on slowly removing some of those things hitting the brakes. So again, as I go through this list, kind of jot down for you personally, or think about in your mind, what is hitting your brakes. So physiological, most common physiological issues that hit the brake pedal. Of course, chemotherapy, the impacts of chemotherapy. If you're not feeling good, probably don't want to be sexual. Medications, like antidepressants, but specifically with breast cancer, if you're on a aromatase inhibitor, you saw before, that really takes the gas out of that gas tank for that spontaneous desire. So that will hit the brakes. Genitourinary syndrome of menopause. Our next speaker is going to talk a lot about this, but I'll give you the brief spiel on genitourinary syndrome of menopause, which I'll also refer to as GSM later on in the talk. GSM is the new term, 5 years or so. It's a relatively new term for what used to be called vaginal atrophy. But then doctors realize that we don't really want to be told our vagina has atrophied. So now it's called GSM. And it's really when you don't have those hormones, and so your vulva and vagina doesn't have that moistness, that plumpness, that lubrication, and then what happens is that can cause pain with penetrative sex. So kind of the big role with GSM, why does it hit your brake pedal? Because you're experiencing pain with penetrative sex. Hormones, again, anything that's going to impact your hormones is going to impact your desire. Fatigue, so I'll ask my clients, at the end of the day, if I were to hand you a platter of sex or a platter of sleep, which platter are you going to take? And lots of people prefer the sleep platter. So that tells you that fatigue probably is hitting your brake pedal. Okay, psychological, emotional factors that most commonly hit the brake pedal. Anxiety. My guess is if maybe you're 2 weeks out from your next kind of 6-month follow-up appointment with your oncologist, in those 2 weeks, you probably don't have much desire because you are thinking about what are the results of this appointment going to be. And when your mind is scanning the environment for threat, it is really difficult to want to be sexual. Because if you think about sexual desire, or just sex in general, a requirement to be sexual is you need to be able to be relaxed. You need to feel like you're in a safe environment. And again, if you are scanning the environment for threat or worried about what this follow-up appointment's going to be, it's really going to hit the brakes on sexual desire. Depression. Hallmark features of depression are you don't experience much joy in life. You don't have much motivation. You're not finding many things pleasurable. And so, of course, that's going to impact sex. Poor body image. If you're not feeling sexy, it's hard to want to be sexual. History of sexual abuse or trauma. If you've had trauma in your past, especially sexual trauma, that may kind of cloud and change how you see sexuality as an adult. Distraction. So the way I'll ask women about this is, so when you're actually being sexual, think about your last sexual experience. What was going through your mind? And if the person tells me, last time I had sex, I don't even know what was going through my mind. I was just kind of like in the moment, enjoying it. That tells me they're not very distracted at all. They're in it. They're in the moment. But if they say, last time I had sex, I was thinking about my to-do list, and when is this going to be over? Distraction's going to hit the brakes. Substance abuse. Some research shows that a little bit of wine can be helpful to take some of those brakes off the brake pedal, but any more than a couple glasses is going to really hit the brake pedal. Okay, relationship factors, most common relationship factors that hit the brake pedal. Conflict. If you're arguing with your partner, you probably don't want to be sexual with them. No emotional intimacy. You saw in that circular model, that circular response model, that the top of that circle was emotional intimacy. So if you don't have emotional intimacy with your partner, that really kind of is a break in that cycle and you'd be able to feel responsive. Partner dysfunction. If your partner is experiencing sexual health concerns, then you're more likely to experience sexual health concerns. Inadequate stimulation. This one's kind of simple, but basically if the right buttons aren't being pushed when you're being sexual and you don't find it very satisfying, that's not a big motivation to want to be sexual. And then lack of privacy. I hear this one so often. I'll share a little anecdote that I've heard multiple times. So couples will commonly say, I'm worried when we have sex because I'm worried the kids are going to walk in the room. And then my first question is always, do you have a lock on your bedroom door? And I have received this answer multiple times. We don't have a bedroom door. What? Go to Home Depot and get a bedroom door. That is the first part of the treatment plan. And then lastly, social cultural influences that hit that brake pedal. If you have limited sex education, you may be believing a lot of negative thoughts or myths about sexuality and sexual health. Conflict with religious, personal, or family values can hit that brake pedal. And societal taboos. I've heard a lot of women say, I don't want to initiate sex because I feel like as a woman I shouldn't be the one initiating sex. So all of these can hit that brake pedal. Okay, so this is what I'll do with my client, and this is what I'm kind of asking you to do either in your head or to write it down or put it on notes in your phone. Creating 4 columns. These are those 4 biopsychosocial columns. Biological, psychological, relationship, and this is a sociocultural, just kind of life stuff, I call it. It's the catch-all. So imagine you've got this piece of paper, and you've got these 4 columns on here, and I really want you thinking about, okay, in each of these 4 columns, what is hitting my brake pedal? So let's say kind of the average woman that I have in my office, breast cancer survivor, she'll say, I've been having, hot flashes and night sweats because of the medication that I'm on, and I'm really not happy with my body image, and I've been just super stressed out and having conflict with my partner, and I'm also stressed because I'm taking care of my in-laws who are older. So maybe this is what she would say are the main things hitting her brake pedal. And there are typically a lot more than just 4 things hitting the brake pedal. When I work with clients, there might be 20 different things on this board. So let's say you've got your 4 columns, you've written down the things that are hitting your brake pedal. The next thing I want you to do is to really look at this list and say, okay, of all these things hitting my brakes, if I could just remove a few of these, 1, 2, 3 of these things, if I could remove a few of these, and I think that will really impact my responsiveness, my kind of willingness or openness to being sexual, what are the few things that really have the greatest weight on my brake pedal? Circle those 1, 2, or 3 things. That is your first step. As you're thinking about improving your desire, increasing that responsivity to be sexual, identify those things that have the greatest weight on the brake pedal, and those are your first step to really try to see if you can get those off the brake pedal. Again, it's not thinking about what can you add to the gas. That will be important later on. Right now, it's what can you remove off the brake. That is the first step. Because for most of you in this room, more than likely your main desire is that responsive desire. So it's really trying to think about, okay, this is going to be a lot more planful. I really got to think about ingredients. This book, Come As You Are by Emily Nagoski, is hands down the best book I have ever read on women's sexual health. It is not specific to cancer survivors, but the information you're going to learn is absolutely relevant to your experiences. You're going to learn about the brake pedal, the gas pedal, responsive desire, spontaneous desire, and then there's an accompanying workbook as well. If you are interested in this, I would say get both, and if you have a partner, read the book with your partner and do the workbook with your partner. It's going to get you two talking about these different types of desire and what desire do you have and what desire do I have and what ingredients need to be in place. So this would be a great kickstart if you're in a relationship to start to kind of get the sexual relationship back. Even if you're solo, not in a relationship, this is incredibly helpful. So here's the take home for low sexual desire. There are 2 types of desire, spontaneous and responsive. With hormonal changes, which could be the result of chemo or aromatase inhibitors or surgery, that responsiveness will probably end up being your main desire. So you really want to work on maximizing your responsivity, and to do that, you got to figure out what are the ingredients that need to be in place. Okay, so that was desire. Now we're going to go to sexual pain. Sexual pain brings us back to Nancy. So Nancy says, we haven't had sex in 5 months. It hurts too much. I'm desperate. So Nancy's pain is caused by GSM, which I mentioned just a little bit ago, genitourinary syndrome of menopause. And I'll explain for a moment, when you don't have those hormones, again, because of chemo, aromatase inhibitors, surgery, all those estrogen receptors in the vulva and vagina, our vulva and vagina have tons of estrogen receptors. Those estrogen receptors are no longer being fed with estrogen, and then as a result, the vulva and vagina, they dry out. You don't have that same level of lubrication. You don't have that same moistness or plumpness. The vaginal canal, which used to be more elastic like a rubber band, loses that elasticity. The estrogen actually facilitates blood flow to the genitals. So if you don't have that estrogen, you're getting less blood flow to the genitals. And blood flow is sexual arousal. So less blood flow equals less sexual arousal. If you have less sexual arousal, it's more difficult to reach orgasm. So estrogen is super helpful for sexual function. And without that estrogen, many of you are going to experience GSM, which is going to cause sexual pain, sexual dryness, just kind of discomfort. GSM is caused by that treatment-induced menopause, again, which could be chemo, it could be aromatase inhibitors, it could be from surgery, like I just said. And induced menopause versus natural menopause is so much more difficult. If you're going through natural menopause, you've got those 5 or so years during perimenopause to kind of let those hormones, let your body get used to the hormones declining. Natural menopause could simply be you wake up from surgery, from your oophorectomy, and the next day you're in menopause. So that sudden onset requires, or involves a lot more severe menopausal symptoms, and those menopausal symptoms may not entirely respond to hormone therapy. Your next presenter is going to talk a lot more about all of this, but I just wanted to kind of plant the seed about how important hormones are. Again, how important estrogen is. Don't want to spend a lot of time on this because the next presenter is going to spend a lot of time on this, but estrogen is just super important for your sexual function, for your vaginal sensation, to get the blood flow to your genitals, for the vaginal lubrication, to prevent sexual pain, to help you with sexual arousal. Estrogen is super helpful. And for many of you, you're not making that estrogen, or you can't have that estrogen because of your breast cancer. So if you are having painful sex, which is probably caused by that GSM, first recommendation, and this may sound a little bit silly, but it's super important, stop having painful sex. And I want to share why that is so important, because again, it may seem like a little bit silly of a recommendation, but every time you have sex and there is pain, sex and pain get connected. So when you even think about sex, what is the first thing that goes through your mind? Oh, Siri's got something that's going through her mind. So yeah, when you even think about sex, what's the first thing that goes through your mind if sex and pain have been connected? Pain. So then why would you want to have sex? Because you're like, oh yeah, that's great, let's have sex, and I'm just going to have an ice pack on my vulva afterward. So if you continue to have sex with pain, you're just strengthening that connection between sex and pain. So that's why this recommendation, which seems really simple, is super important. Stop strengthening the connection between sex and pain. So stop having painful sex. So that's recommendation 1. And what happens over time when you have painful sex is this avoidant dynamic gets created. And I'm going to describe the avoidant dynamic now, but we're going to revisit it at the end of the presentation. So here's what the avoidant dynamic looks like. And this is the most common dynamic I see with couples in sex therapy. So one partner says, yeah, do you want to have sex? And the other partner's like, no, this is painful, I don't want to. And this partner goes, well, my gosh, I don't want to pressure you in any way, so I won't initiate. It's up to you. If you want to have sex, you can initiate. And of course, the person with pain is like, I'm not going to initiate because it's painful. So then sex just stops. And the avoidant dynamic has this really gnarly ripple effect. So sex stops, and then over time, it ripples to that non-sexual physical affection. So this is where one partner is like, well, usually I would go up and, and hug and kiss my partner, but I don't want her to think that I'm initiating sex because I don't want her to feel pressured, so I'm just not going to go and hug and kiss her. And the partner with pain says, well, usually I go up and, snuggle with my partner, but I don't want my partner to think that I'm initiating sex because it hurts, so I'm not going to. So now the couple is not touching the way that they used to touch before, that non-sexual physical affection. And the longer that time goes on, then it starts to take a hit on the emotional connection. And this is where couples come into my office and they say, we just feel like we are roommates. So really commonly, if you're continuing to have painful sex, it's going to turn into that avoidant dynamic. You're going to start to avoid because of the pain, and then eventually it's going to have those ripple effects. We'll talk at the end of the presentation on how to break that avoidant dynamic if you're in it, or how to prevent it, but this is a really common side effect of continuing to have painful sex. Step 2, so step 1 is stop having painful sex, and step 2 is to see, are there any over-the-counter options that could alleviate that pain? Again, the next presentation is going to talk a lot about this, so all I'll say is the most common over-the-counter options are moisturizers and lubricants. You'll learn a lot more in the next presentation. What I do want to share as a step 2 is there is a new sexual menu. What causes the pain when you're being sexual? Oftentimes what causes the pain is vaginally penetrative sexual activities. Is that what causes the pain? Is some other sexual activity what causes the pain? Whatever causes the pain, can you stop doing that, and can you create a new sexual menu? So perhaps this new sexual menu is a non-penetrative sexual menu. I have on my website, which is just my name, Jordan Rullo, I posted a blog for this conference, and you can download a sexual menu for free. Download a sexual menu to kind of expand and create different sexual activities that might not be painful. But online, there's also Mojo Upgrade, which is a free sexual menu, and We Should Try It, which is another free sexual menu. So if you're thinking, okay, yeah, we keep having sex this way, and this way is painful, are there other ways we can have sex? Consider doing a sexual menu. And then a vibrator. I mean, you can't have a sex therapy talk without talking about vibrators. So I do want to talk about adding in some accessories as a way to expand or change your sexual menu. Recommendations for vibrators. Let me give you some data on vibrators. Over half of women, 53% of women, have used a vibrator at some point in their life. If we're talking women who have sex with women, that number jumps to 85%. And here's a couple examples of vibrators. This is a vibrator for external stimulation. So this is not, it's not internal, it doesn't go in the vagina. It's for external, that clitoral, outer clitoral stimulation. And this would be an internal and external vibrator, both for penetration and non-penetration. If you are considering getting a vibrator, think about how vibrators are really good for not only your sexual satisfaction, tons of research showing how vibrators improve sexual satisfaction, but vibrators are good for blood flow. When you're doing that vibration, you're helping enhance sexual arousal, you're getting more blood flow to those genitals. If you are interested in getting a vibrator, I have a little vibrator prescription for you. Get a silicone vibrator. You don't want cyber skin or jelly rubber. You want kind of a medical grade silicone vibrator because those are going to be the safest and easiest to clean. For more variety, you can get one that does both internal and external use, but if you are having pain with vaginal penetration, you probably don't want a vibrator that you use internally. Like, internal is what's causing the pain, so maybe you just get an external vibrator. Just clean it with soap and water. That's all you have to do. Clean it with soap and water. Do not share it with others. I hope that goes without saying, but maybe some of you are very kind and you want to share it. And then don't switch between orifices. So don't use it for the anus and then bring it to the vagina. Just one orifice, clean. Okay, and then the last thing, again, the next presenter is going to talk a lot about this, but if you're having sexual pain, stop. Consider some over-the-counter options or a new sexual menu, and then there are a lot of different prescription options for genital urinary syndrome and menopause that will be talked about in the next presentation. But this is kind of your 3-step plan if you're having sexual pain. So here's the take-home. If you're having sexual pain, it's probably from that treatment-induced menopause that has caused GSM. So stop having that painful sex. Think about some over-the-counter options, lubricants, moisturizers, maybe expanding your sexual menu. There are prescription options, which will be talked about in the next presentation. Okay, we're going to talk about poor body image now. This takes us to Kelly. So Kelly says, I can't even look at my breasts, let alone let my wife look. I haven't let her touch me since my surgery. It is hard to want to be sexual if you don't feel sexy. I know I've said this a couple times already, but yeah, that's true. If you're not feeling good about your body or your body image, you're not feeling very sexy, it's hard to have desire, want to be sexual. And then maybe your body has changed because of surgery, mastectomy, and then you think, well, I don't even think my partner's going to find me attractive. Like, I'm terrified to show my partner my chest or my breast. They're not going to find me attractive. And then, of course, that's going to hit the brakes to wanting to be sexual. So what do you do if you're having some of these thoughts? Mindfulness. So mindfulness is being fully present in the moment without judgment. And there's been some really good research showing that mindfulness can improve the way you feel about yourself, your body, and also improves sexual function. Another way mindfulness has been described is it's called non-reactive awareness. Imagine being totally aware in the moment of everything as it is and not judging it and not wishing it would be different and not reacting to it, but just being like, okay, it is what it is. Mindfulness is super powerful in that way because you just get to be with whatever you're being with, whether it's your body, wherever you're at, you just get to be, and there's no negativity, you're not wishing for anything different, you just get to be. Like I said before, it's been shown to improve desire, arousal, even reduce sexual pain, and for men it's been shown to increase erectile dysfunction. And there have been some amazing studies on mindfulness and sexual health, specifically for women and women cancer survivors. Mindfulness is incredibly helpful for sexual health and to get you tapped back into your body. You can do mindfulness solo, or with a partner. You can do it anytime. It's super versatile. So if you are interested in learning mindfulness, what I would recommend is just start learning it non-sexually. Don't learn it in a sexual context. One really great intro to mindfulness is to do a mindful eating exercise. We're going to do a mindfulness exercise right now that's not a mindful eating exercise, but it would be similar to a mindful eating exercise. So I'm going to put 3 minutes, well, I'll do it in a moment. I'm going to put 3 minutes on my timer, and we're going to do mindfulness right now. So for everybody, can you grab something? You can grab a pen. You can grab your coffee cup. Something that you have on your person. I want you to take it and hold it. So everyone has something. It could be your phone. Doesn't matter what it is, but take something. Okay, it looks like everybody's got something. Great. Okay, now I'm going to start 3 minutes, and we're going to do a 3-minute mindfulness exercise. So I want you to suspend your judgment on this thing. When I say suspend your judgment, imagine you have no idea what this is. You've never seen this before. You're an alien, you've come down here and you're like, what is this? So really, suspend your judgment. And I just want you to take this thing and just put it on your hand. And I want you to take a look at it and describe factually everything you notice. And when I say factually, you're describing, like, for example, I've got my remote here, but I don't know it's a remote, right? I'm just like, I don't know what this object is. So I'm describing it. I'm saying, okay, it's black. It's kind of light. There's like a cave or a hole here that's even darker. So I'm factually describing it. I'm not saying things like, oh, it's pretty. Oh, this part's kind of ugly. Like, nope, those are all judgments. Core part of mindfulness is no judgment. So I want you to take a moment, just on your hand, and factually describe everything you see. So you can do it in your mind, just what is everything you see? How does the light bounce off of this object as you kind of move it around in your hand? What's the weight of it? What do you see? Okay, then next, I want you to take it with your other hand and hold it in your hand. And now you've got a lot more data points. Now, what do you feel? Like for mine, this is smooth, but it's got some bumps on the back. Just what do you feel? Is it smooth? Is it rough? What's the temperature? So take a moment and everything that you feel, just factually about this object. No judgment, just the facts. Okay, so now I want you to take this object, and I want you to put it up to each nostril and smell it. And really pay attention to beginning, middle, and end, that smell. Do both nostrils, does it differ from each nostril? Does the smell like intense at the beginning and then less intense at the end? Just factually describe in your mind what that smell is. And then next, I want you to take it to each ear. And whatever this object is, just kind of rub it between your fingers. And do each ear. And what do you hear? Again, factually describe. For mine, I hear like some clicking as I rub it between my fingers. Okay, so that was almost exactly 3 minutes. That was a mindfulness exercise. And I'm curious, how many of you, or whoever wants to share your experience, were you distracted? Were you thinking about other things? Were you really in the moment on this object? Does anyone want to describe what it was like to do this with their object? One single person? Thank you. Yeah, so you had not looked at your phone case in that detail that you're like, oh, this is broken. But even I would add in there, a little bit of judgment comes in that this is broken. If you, was something cracked? Okay, so she's saying there was a spot that was white on it. And so it sounds like you were very mindful and you're like, there's a white spot here. And then your mind drifted a little bit and you're like, my case is broken. And then I wonder if you went to like, should I replace it? Or how did this happen? But so mindfulness is just, okay, there's a white spot. And then maybe your mind starts to drift and you think, oh, my case is broken. Well, how'd that white spot happen? And then you just say goodbye to those thoughts that have judgment in them, goodbye, and you go right back to, okay, I see this white spot, okay, what else do I see? So that's mindfulness. It is super powerful because it's allowing you to be with whatever this object is, or your body, without judgment. Imagine being able to do this exercise with your body, and as you're touching your chest, as you're touching your breasts, you're just saying, okay, this is warm, this is cool, this is kind of firm, this is soft. No judgment. It is giving your mind a break that you can just be with your body as is without being negative toward your body. And my guess is for those of you who have been struggling with your body image, when you're with your body, there's probably a lot of negativity happening. So this is a shift. You're taking a detour in your mind to not go down the negative highway and to just go down the neutral highway, just to be factual. This is the first step to eventually getting more connected and feeling better about your body. I mean, if we think about this as a continuum, over here is feeling really negative about your body, over here is tons of body positivity, and right here is the middle, neutral. Mindfulness says, let's just get you to the middle. It's not asking you to jump over here and be really positive about your body. It's saying, no, let's just remove the negativity and get you to be factual and neutral with your body. That's the foundation to eventually move toward positivity. There are, online you can just Google body scans. You can do a body scan solo, you can do it with a partner, but if you just Google like mindfulness body scans, a body scan is an exercise where you start at the top of your head and you scan all the way down to your toes, and you're just giving that neutral awareness to your entire body. Often body scans can be 20 minutes, they can be up to 40 minutes. But the research on mindfulness that shows that it's really impactful for women in their sexual health asks women to do a 20 to 40 minute body scan every single day. And these research studies asked women to do this for 8 weeks and showed significant improvement in how they felt about themselves and their sexual health. And I mentioned, we got Sensate Focus here. That is a partnered kind of body scan exercise. We're going to talk about this a little bit later. This is a really great book if you are interested in mindfulness. It's called Better Sex Through Mindfulness, and it has an accompanying workbook as well. This is a great TED Talk. Andy Puttycombe created an app called Headspace, which I'll show a clip on that in a moment. But really great TED Talk just to learn some of the basics of mindfulness, because I've only described it really briefly right now. Headspace is the app that Andy Puttycombe created. You can download it on your phone, and I believe you get a week free, so you get a week to try out different mindfulness activities. It's just little short bursts of mindfulness activities. If you like it, then I think you pay per month. But then every morning you'll have a new mindfulness activity to do, or anytime you're feeling a little bit of stress, you can do a mindfulness activity. Okay, last thing I'll talk about today is the avoidant sexual dynamic, which I mentioned a little bit earlier. Let me describe a little bit about sexual relationships in general, and then we're going to dive into how this relates to the avoidant dynamic. So you saw this picture before. This is the circular model of sexual response. If your main sexual desire is that responsive desire, this is probably going to be what your sexual response looks like. It's going to be much more planful. You're going to need to be receptive to ingredients. There needs to be some sort of stimuli. Arousal starts first, desire on the coattails, some type of satisfaction, feel emotionally close to your partner, and then that cycle continues. Now, for many of you, you may have a partner who has a different type of sexual response. They're more in that spontaneous desire. And this is what their sexual model is going to look like. This is called the linear model. It's a lot simpler. The linear model just looks like this. I want to have sex, now I'm aroused, that leads to orgasm, and then what's called resolution phase, which is kind of like cuddle time. So I want to have sex, body's aroused, orgasm. Oh, and you see these 3 different lines. That's because research shows there's kind of 3 different types of orgasms. There's like one big orgasm, there's a couple big orgasms, or there's this long, little, drawn-out orgasm. You may be in a relationship, if you're in a relationship, you may be in a relationship with your partner is much more this linear model. They're much more spontaneous desire, and you're much more responsive desire. And this can cause some conflict, because the person who's much more spontaneous desire, think of this person as like the microwave. Spontaneous desire, you just hit a couple buttons and boom, you're hot. Super easy, super quick. But you're the crock pot. Ingredients have to get in place. They've got to simmer throughout the day for things to get hot. So your microwave partner is like, why do you not want me? Why are you not getting hot really quick? I feel like you don't desire me. And you're like, I do desire you. I just, like, more things got to be in place for me to get hot. And maybe you're thinking to your microwave partner, like, how do you get like aroused so quickly? How can I just like walk out naked and you're aroused? Like, how is this happening? So nothing is wrong. Neither desire is right or wrong. It's just that you simply have different ways that you experience your desire. And so it's about talking about these different ways and then trying to figure out, okay, well, how do we make this work for both of us? If you need ingredients, what ingredients can we get in place? So it's just having that discussion, having a better understanding of how each of you work differently in this realm. So your sexual response cycles may differ, and your partner may not totally understand your responsive desire. So talk with your partner about the ingredients that you need to have in place in order to be responsive. And emotional intimacy, that's the top part of that circle. Emotional intimacy is a super important part of those ingredients. And then remember, and I know I emphasized this a little bit earlier, but if your main desire is that responsive desire, you're that circular model, arousal kickstarts your desire. And then arousal, body's got to get aroused, and then the mind says, oh yeah, I'm glad we're doing this. This is why, like I mentioned earlier in the talk, I have so many clients that say, well, I'll put on Outlander, or I'll put on Bridgerton, because they realize, my partner may say, you want to have sex? Like, I'm not going to do it. It's not going to do it. Something's got to kickstart the arousal. So that's why they know, okay, I know if I put these shows on, if I read this book, that's what kickstarts the arousal. All right, so now let's tie this back into the avoidant dynamic. What if you and your partner are in that avoidant dynamic? And just as a brief reminder, that avoidant dynamic is initially you're both avoiding sex, then you're starting to avoid that non-sexual physical touch because you think, oh gosh, I don't want to go up and touch my partner because I don't want my partner to think that I'm initiating sex because I'm not. And then over time that goes to that we just feel like we're roommates. So what if you're in that avoidant dynamic? This is where sensate focus exercises that I mentioned a little bit earlier are incredibly helpful. I'll tell you the basics in a moment, but sensate focus exercises, these are a mainstay of sex therapy. So if you ever see a sex therapist, they're probably going to teach you sensate focus exercises. These are developed in the 1960s, and we still use them today because they're essentially mindfulness exercises. So what these are is they're touching exercises where you and your partner are going to set aside time to just touch. But the touch has very specific guidelines, and you and your partner agree, no sex. These are not sexual exercises. You're not having sex after you touch. You're not having sex while you're touching. It's just touch. And that's really powerful, because if you two have been you've been avoiding sex, then you're starting to avoid touch. Imagine saying, okay, we're going to touch again, but we have really specific rules and guidelines on how we're going to touch again. It makes it feel a lot safer, and it gets you back in the groove of touching again. So here are the basics of sensate focus exercises, and there are phases, and I'm just going to share the first 4 phases today, which are the phases that will really help you get started if you're interested in doing this with your partner. So you do these in a private space, these touching exercises, and most of my clients do 20 to 30 minutes of this full body touch, but I've absolutely worked with couples that say, we cannot find 20 to 30 minutes, or that feels overwhelming to do that length of time. So I'll say, okay, 10 minutes, just 10 minutes trying to be really mindful. A quality 10 minutes is better than not doing it at all. So you really can tweak the amount of time. You are new to whatever extent feels comfortable. For many of you, you may not feel comfortable showing your chest or your breasts right now, and that's okay. New to whatever extent feels comfortable. If you want to wear a bra, if you want to wear a t-shirt, that is totally fine. You may want to wear some level of clothing as this gets started, just to get it started, just to feel comfortable as it gets started. No sexual activity is allowed. This is so important, because if you think, okay, well, we're going to do these sensate focus exercises, and then you think, and it's just going to be basically foreplay, it's just going to lead to sex, and my partner's going to initiate sex, are you going to want to do these exercises? Yeah, probably not. So you and your partner really have to agree, there is no sex. There is no sex connected to these exercises at all. These are simply touching exercises. What we know from the research is that ideally you do these exercises every 48 to 72 hours. I can tell you with the couples I work with that often does not happen with busy lives. So at the bare minimum, I would want you to do these exercises once a week with your partner. These are mindfulness exercises. So you're building your mindfulness muscle. The more you can do it, the better, but just once a week would be kind of the minimum recommendation to get benefit out of it. And like I said, there are phases that build upon each other, and I'm going to share with you the first 4 phases. Phase 1, full body touching, except for in this phase, there is no touching of breast, chest, or genitals. Those are off limits in this first phase. Part of that is because those are those traditionally kind of erogenous zones, and these are not sexual exercises. So we're really trying to set these up as just touching exercises, not sex, so that's why those zones are off limits. But for many of you, you may not be feeling comfortable with your breast or chest, so it's kind of nice at the beginning to just have that off limits. So just have it off limits, and let's just get touching again in other areas. No sex, cannot stress that enough. These are nonverbal. You're not talking during these exercises. You're going to take turns touching. So let's say you do 20 minutes. 10 minutes your partner's going to touch you, then you say switch, then 10 minutes you touch your partner. And you're using your hands and fingers only as you're touching. I cannot tell you the number of couples I worked with that are like, can I use my tongue? No! Hands and fingers only. These are not sex. And you are touching for yourself. This is incredibly important. When I say touching for yourself, again, think about these as mindfulness exercises. You're touching your partner, and you're focusing on temperature, pressure, and texture, which I'll talk about in a moment. You're focusing on the sensations you feel as you touch your partner, and you are touching just for yourself. What do I feel? What do my fingertips feel when I touch my partner? You are not touching to please your partner. A lot of couples will start these exercises and they'll think, ooh, I'm gonna massage this knot out, and I know my partner really likes this, and they like the tickle. No, you're touching for yourself. Because the moment you start to touch for your partner, then you're wondering in your mind, I wonder if my partner likes this, am I pleasing them? And now there's pressure. There's pressure that you're supposed to be doing something, that this is supposed to feel some way. And remember mindfulness. A core of mindfulness is there's no judgment, there's no pressure, you just get to be as is. So if you're touching for yourself, there's no pressure that you should or shouldn't be doing anything. You just get to touch the way you want to touch and focus on those sensations. So you're focusing as you touch on temperature, pressure, and texture. So temperature, as you're touching your partner's body, is this warm, is this cool? Pressure, firm, soft. Texture, rough, smooth. TPT is going through your mind as you're touching your body. And think about the object, the mindfulness exercise we did a little bit earlier. That's essentially what you were doing. Is this firm, is this soft? Is this cold? Oh, this is smooth, this is slippery. But you're doing it with your partner's body. These sensations, they're vivid, they're reliable, they're kind of always available. TPT is always there no matter what you're exploring. So phase 1, breast, chest, genitals are off limits. Phase 2, now all body parts are on limits. Again, no sex. These are also nonverbal. Full body touching. You take turns. So all the same rules apply, but in phase 2, all body parts are on limits. And that may be really anxiety provoking. Again, if you have not let your partner see your chest, if you haven't even looked at your own chest, if you're afraid about what your breasts are going to feel like, if your partner touches them, you're going to feel numbness, or this might be a scary step to go to phase 2. So what I would recommend is do not leave phase 1 until you feel like you're fully in that mindfulness zone, you're not distracted when you're doing these exercises, and then you're starting to feel a little bit bored. When those things are happening for you, then you know, okay, I'm ready for phase 2, and phase 2 may seem a little bit scary, but you're ready for phase 2. And again, you're touching for yourself. Phase 3 is the same as phase 1. Breast, chest, genitals off limits, but now you're touching at the same time. So phase 1 was breast, chest, genitals off limits, take turns touching, but now you're no longer taking turns, you're touching at the same time. And phase 4, same as phase 2, all body parts are on limits, but instead of taking turns touching, which is what was happening in 2, you're touching at the same time. So these are the first 4 phases of sensate focus. If you and your partner are avoiding sex, or it just feels awkward, or you're not feeling comfortable with your body image, or showing your partner your chest or breasts, this is a great way to get started touching again with really clear guidelines that helps it feel safe. And it's not sex. It's just getting you touching again in a mindful way without judgment. I skipped over it. If you wanted to learn more about sensate focus, this is the only book on the market that talks about it. It's a really boring book, but because I think it's mostly kind of written for therapists. But if you really wanted to learn more and you don't want to see a sex therapist, you just want to do kind of self-help, this is a great step. But just like brace yourself; it's some tough reading, but it's in there. Okay, so take home on sexual relationship. Your sexual response may differ from you. Your sexual response may differ from your partner's. If you have that circular sexual response, that responsive desire, you're going to need arousal to kickstart it. Emotional intimacy is a necessary ingredient. And if you're in that avoidant dynamic, think about sensate focus. And if you want someone to help guide you through that, think about actually going to sex therapy. If you're looking for a sex therapist ASECT is kind of the gold standard for sex therapists. It's the American Association of Sex Educators, Counselors, and Therapists. You can go to asec.org, and there's a tab where you can find a therapist. And there are about like 15 to 20 of us, of certified sex therapists here in the state of Utah. And ISHWISH is a great place to go to, the International Society of the Study of Women's Sexual Health, if you want a sexual medicine provider, like a physician or PA who can prescribe medications for sexual health concerns. Overall take-home message of this entire presentation: breast cancer does not take away your sexuality. Maximize your responsiveness with the right ingredients, and then share this information with your partner. If you're having painful sex, stop. Try moisturizers, lubricants, a non-penetrative sexual menu, and then talk to your doctor about GSM. And if you're in an avoidant dynamic, sensate focus, or think about sex therapy. Thank you, and I don't even know if we have time for questions. We're going to wait till later for that. Oh, we have 5 minutes if anyone has questions. Yes. Yes, phase 1 and phase 3. And I'm also happy to, I don't know if these slides can be shared or sent to participants, or I'm happy to share these slides. But let me go back to phases. So phase 1 is, there's lots of stuff to get there. Full body touching, breast, chest, genitals off limits, and you take turns. Phase 2, same thing, but you have all body parts are on limits. So breast, chest, genitals were off limits in 1, now they're on limits in 2. And then 3 and 4 are pretty much identical as 1 and 2, but instead of taking turns touching, you're touching simultaneously, which can get a little tricky, because imagine maybe you choose to be in bed and you're touching each other and you're like, wait, I can't touch here, wait, I can only get to this part. So it can be a little bit tricky, but it can be kind of funny too, and you and your partner are talking about it, and then you're touching again, and you're touching again, you're kind of have fun as you're trying to figure it out. So it's okay if it's a little tricky. So yeah, 3 is the same as phase 1, touching simultaneously. 4, same as phase 2, touching simultaneously. Oh, time limits for sensate focus, like too short or too long?
Yeah, like each phase.
Oh, like how much time you spend in a phase. Such a great question. So is there a time limit on how much time you spend in a phase? There's no time limit. You want to be experiencing 2 things before you move to the next phase. 1, you really feel like you can be in that mindfulness zone when you're doing the touching. You're not distracted. You're present with that TPT, temperature, pressure, texture. And 2, you're starting to feel a little bored. When those 2 things happen for you and for your partner, then you know you're ready to go to the next phase. Now that may mean that you do phase 1 3 times, and then you're ready to go to the next phase. I have worked with couples that do phase 1 4 months before they go to phase 2. If we think about those foundational principles of mindfulness, there's no pressure, there's no demand, there's no expectation. So if you can just let things be as is, think about it, it's not about getting to the finish line. It's not like, we gotta get to phase 4 as fast as possible. It's the journey. It's every time you're doing it, and you're being able to be with your body with that non-reactive awareness, that is what you're getting out of it. It doesn't matter how long it takes to go through a phase. It's the journey. So great question. Yeah. Oh, yes, the Better Sex Through Mindfulness. Let's see, where is that at? I bet you I could go on here faster. So the mindfulness book is Better Sex Through Mindfulness by Lori Brado. There it is. And this book talks about sensate focus too. Yeah. Yes, all those physiological things that hit the brake pedal. I'm sure there's a much faster way I could do this, but this is just how it's going to happen right now. There we go. Any other questions? And again, I'm happy to share these slides. Yeah. Ooh, is it okay if your partner masturbates when you're not in the mood, and should he be involved in that? Well, okay. It's okay if your partner masturbates if you and your partner within your relationship agree that masturbation is okay in your relationship. If you both agree, yes, masturbation is a part of our sexual menu, we're okay with that in our relationship, and it's not something that's hidden or shameful, then absolutely. Masturbation is an incredibly helpful way to bridge the gap on what's called desire discrepancy. So desire discrepancy is just the fancy sex therapy term we use when your partner has, either you or your partner, someone has a lot higher desire than the other person. So if someone has a lot higher desire than the other person, what does not work well is the higher desire person constantly demands the lower desire person to be sexual. Well, I want this, and I want this more frequently, and we're not doing this enough. And then the lower desire partner is like, this just feels like pressure, this feels like obligation, like this is no fun for me. So part of being able to bridge this is if the higher desire partner can learn, oh, I don't have to demand that my partner meets all my sexual needs. I can meet some of my sexual needs. And I can meet some of my sexual needs with masturbation, or the term I use is self-stimulation. Like, that's really helpful to realize you can meet some of your own sexual needs. It doesn't all have to be on your partner. And what was the second question? Should you be involved in it? That's a discussion with your partner. So if you're saying to your partner, hey, I don't really feel like being sexual, I'm not open to it, I hear that you want to be sexual, I'm happy to like rub your back while you're self-stimulating or hold you while you self-stimulate, like that's what I can offer. If you feel like you can be open to that and you don't feel obligated and it doesn't feel like pressure and you're not going to resent your partner as a result of doing it, then absolutely that can bring connection. Great, great question. I don't know, we're at time, okay. Thank you, everyone.